Hello,
I think we're live.
everybody. Is anybody out there?
I think we're definitely live, James.
Okay.
Hey, everyone.
Hi, everybody. Welcome, and thank you for waiting here. My name is Dr. James Tran, and I'm here on behalf of GDR, and we also have Dr. Alex Khominsky also on behalf of GDR. We are here to, hi, Nicole. We're here to talk about atraumatic extractions. So if you haven't been here before, I'll just give a quick introduction for Alex. Dr. Alex Khominsky graduated from the University of Adelaide as Dux, and he went on to work at the Alfred Hospital and afterwards private practice in Melbourne. He's a firm believer in the power of community and supporting other early career dentists in the pursuit to be amazing clinicians. In light of his experience as a graduate, he co-founded an education institution, GDR, which focuses on comprehensive education through a unique program supported by ongoing mentorship. He has been a clinical demonstrator at the University of Melbourne and completed his specialization in periodontics back in Melbourne. And now he balances his time between private practice in the southeastern suburbs of Melbourne, Wodonga, and in education. He's also a committee member of ASP Victoria and a study club director of ITI Melbourne. Welcome, Dr. Alex Khominsky.
Thanks, James. Thanks, everyone, for the introduction, and thank you all for joining. Today I'm going to deep dive into extractions, minimally traumatic extractions. If you're willing to say hi in the comments and say where you're from and where you are in your dental career, that's always great as well. I'm currently in our regional practice in Wodonga, which is on the border with Albury, so kind of in a more intimate hotel environment today, but looking forward to presenting, and we'll kind of kick it off really soon.
So yes, as we're loading up the slides, Alex, I'll just remind everybody we'll go through any question and answers at the end. So we'll talk for about half an hour or 45 minutes, and at the end we'll hopefully end by 8:30.
Sounds good. So today's topic is extractions and minimally traumatic extractions, and trying to kind of reframe the mindset of how to approach extractions. I feel like extractions often are not approached as strategically in dentistry as perhaps, composite restorations. And we kind of think about, okay, what are the steps required to fulfill a great composite? Okay, we've got to get, tooth preparation has to be done correctly. We're looking at, the cleanliness of the DEJ border. You're looking at your cusps. You're looking at load. You're looking at isolation. Then you're looking at incremental. And so you have this list of steps. With extractions, it's kind of like, let's grab the tooth. Let's start moving. Let's see if, movement happens. Well, if movement doesn't happen or movement does happen, then we'll, think about next steps later. And I think what I'm trying to reframe here is try and approach extractions in the same kind of, academic pursuit as you do every other aspects of dentistry. So James has already introduced me. Hello, I kind of won't repeat it. Follow me on Instagram and follow GDR Instagram if you already haven't. Kind of try and post more cases and show stuff with the beauty of education, perio, extractions, all kind of in the mix of it. So I'd love to see you there. So for the next 30, 45 minutes, we're going to cover surgical setup and equipment, informed consent, case selection and risk assessment, local anesthesia, mechanics and anatomy, minimally invasive techniques, surgical techniques, and then complications. So it's going to be a pretty jam-packed next 30, 40 minutes. This will be recorded and left live on YouTube. So if you feel like I'm going through things and you want to rehash and look back later, you'll have that opportunity. And let's just dive into it. So surgical setup. So once again, I think where extractions can commonly be undone is not being prepared. Often you may have a very basic initial setup. You might have a luxator and one forceps. And then hopefully by the end of, this next 30, 40 minutes, you will kind of think about, okay, what case do I have? How am I going to approach it? and be more prepared. And one thing I will say is initially there can be this, hindrance to having more instruments set up. But, think about it this way. Imagine I told you, I just gave you a flat plastic and, one other instrument to do all your composites. It's just not the case. There's a reason why we have a kit. We have a kit not because we're going to necessarily use all the instruments, but because in reality, most of the instruments or different instruments will help us deliver a better result quicker. And so, the extent of the equipment setup doesn't have to be that cumbersome. And then once your mindset shifts, then as you do this on more of a repetitive basis, your nurse's mindset will shift as well. And it'll become easier and not a one-off thing, but something that's set up all the time. Now, this is probably as extensive as a surgical setup needs to be. So, if you're going to be doing surgical wisdom teeth or, clearances, then you may want to start thinking about a setup like this. We'll fine-tune this a little bit, but it is important. And the concept I'm trying to get here is being prepared. Having a handpiece, a surgical handpiece, and having that set up more often is also going to happen to be the way that you can do more minimally traumatic extractions on a more regular basis and to be more efficient and more comfortable for your patients. You'll find a preference here, but in terms of having, luxators that you go to, we'll discuss this in terms of having your LA, in terms of having your suture setup, in terms of having things like bite blocks, and not to be understated in things that can help you be much more efficient. And what we're trying to kind of go here is not to be in a situation where every 5 minutes, because you haven't moved or progressed the extraction, you keep asking your nurse to get you another instrument. So they have to deglove, get you more, come back. So let's start with luxators. So with luxators, I think it's important to start getting used to using a combination of different luxators. Now, you don't have to make this overly extensive. Personally, I like to have for any molar a size 3 luxator, for any anterior a size 2 luxator. Now, a size 5 luxator is a larger luxator, good if your bone and width and bone preservation is not as critical. So that's always also a good one to have on hand. And then when you're starting to do wisdom teeth in particular upper wisdom teeth, having luxators with a curve. So not just your straight, but a curve. Just gives you that access and leverage, getting behind the distal of a 7 to elevate the third out. Now, James, I don't see any questions. So if questions pop up, you want to interrupt me, please let me know. But we'll otherwise answer all the questions at the end. Forceps. Now, in terms of forceps, what are we thinking? We need to have, again, we're now thinking minimally invasive. So you want to have a set of, upper universal, upper fine forceps. In terms of molars, you can consider molar forceps. And we'll talk about when would you use a molar forceps, when would you be sectioning the tooth, when will you be delivering. In terms of lowers, lower, fine or lower universal is probably what you're looking at. So now the next 30 minutes, I'm not going to focus too much on third molars. I will touch on it, but we're going to kind of focus inwards of that just because that kind of changes the landscape of what we're trying to do here, which is focusing on minimally invasive extractions. So just to give you feedback, personally, I will have usually 1 or 2 forceps for a particular case. And often I'm not using molar forceps because I'm sectioning pretty much all of my molars with some exceptions. And then for lowers, same thing. So it's sort of usually having 1 universal or 1 uni or 1 root forceps. So something that is relatively fine. Now, surgical handpieces, I think, is really important. And for those who are already using them regularly, fantastic. For those who aren't, you need to get in the habit of it. Now, I think depending on your training and preferences, and also the type of surgery you do, you may have a preference for an angled straight handpiece and the burr selection, or you may want something that's more contra-angle. Doing a lot of third molars, a kind of curved straight handpiece, NSK has a nice range. is a nice way to go. But personally, a lot of my extractions are not that way. And even in the cases where I do need to do third molar extractions, I find these 45-degree surgical handpieces important. Now, remember, it has to be re-eventing so you don't have the risk of an air emphysema. And if you're starting to do fairly invasive surgical extractions, thinking about it connecting to a motor and having saline running through it. Now, once you've selected your preferred handpiece, try different types. Your burr selection is incredibly critical. I find one of the kind of key issues that a lot of people have is, they are slow sectioning teeth or find that their burrs do not access the areas that they need to. So there's two burrs predominantly that I use. One is this tungsten carbide Comet burr. I've provided the exact specifications there. This is a long access fine carbide burr. This is fantastic for once you have decoronated and you need to do very delicate and very precise bone or tooth removal or tooth sectioning. And it also has an incredibly long reach. So by doing so, you can very easily access towards the apex of a root. So even if you do fracture and there's a 3-4 mil root piece left over and you need to remove it, this burr will allow you to access, which can be very important to not have to do very traumatic extractions where you have to remove the entire buccal plate to get to that point. Then my kind of secondary burr is also a carbide burr. This is from a Rossler group, coming in different sizes, but you do want the longer shank again. So an FGXL or FGXXL. This burr is fantastic for sectioning and decoronating. It goes like butter. Very fast, very efficient. Other burrs that I will use, if you have a crown on the tooth and you need to section and remove the crown, I might try and initially see if I can get forceps on the crown. So let's say there's a PFM or zirconia, and if the bonding or the secondary decay, maybe the crown will come off. But if I'm starting to place too much force, I prefer to section the crown. And so having a small jet burr to remove metal, having a diamond, varying types of diamond to section different ceramics, are also kind of burrs that I will pre-assess, but these two are my go-to. Now, in terms of retractors, luxators, and bite blocks, again, have a think about, do I need a Minnesota? When you're starting to section and have these burrs in, you do want to be able to control where the cheeks are, where the tongue is. How you do this is up to you. My preference, I don't use tongue retractors as much, although if you do GA, you may want to do that. It's a little bit easier. However, Minnesotas and bite blocks, when you're starting to do more extensive extractions, having support of the jaw joint is really important, because that can be a limiting factor sometimes in terms of access, but also patient fatigue. Suturing, finding and having sutures and needle holders ready. Once again, you're starting to do more extractions. You also, and I guess part of this is also building on skill set. If you want to start doing more extractions, you want to build the skills that are required for those. So one is raising a flap. 2, sectioning, decoronating. 3, bone removal. 4, delivery of the tooth. 5 is suturing. So you don't want to not suture until you get to these complex cases, because that's the last thing you do. And by that point, you may be fatigued of a procedure. So build your experience suturing now as much as you can. So try and suture wherever you feel is indicated, molars, having collagen dressings and as such, and build that skill set now when it may be not as critical, but may improve patient experience, so that when the time comes when you start building on your skill set, you've got that experience a little bit better and you'll be a little bit faster. Personally, having the Hagar or Mayo forceps, especially if you're doing more third molar, you want something with longer reach, longer access. As a periodontist, I've got used to my castros, and that's kind of my regular. There's a finer set of castros that I use for soft tissue surgery. However, my regular castros I would use even for third molars these days. In terms of needle holders, again, you can get as fancy as you want. You have Adson Browns, you have corn sutures, you have tweezers. Again, tweezers can work, absolutely fine, but you may have a particular preference. Just remember, what is the goal of what you're trying to achieve? One thing I wanted to mention with all of this is make sure your equipment is usable. If you have tweezers that when you pinch together, or you have suture holders that when you pinch together do not hold your needle, that equipment needs to be serviced. Otherwise, your needle is going to be constantly moving and you're not going to be able to use it. If your burrs are blunt, for example, with this tungsten carbide burr, if I've decoronated and sectioned 4 or 5 teeth, this burr may need to be thrown out because at that point it is potentially too blunt. When you're starting to suture, you have to have your castros. Having a cheek retractor, especially if you're not using something like an Obtrugate, is very helpful, especially with the assistant, and then having a set of scissors. In terms of sutures, again, you kind of want to build this system and habit and have things ready. My go-to will be a 4-0 chromic gut for most extractions. If you go into soccer grafting, you may want to use something that has more long-term resorbable, such as glycolon or monofast. But plain gut can also work very well. Remember that in terms of sutures, you have resorbable and non-resorbable. Often for the extractions, especially without grafting, resorbable is the way we want to go. And then third, the second thing we're looking at is the actual material, and is it a monofilament or a poly or braided? We're understanding that a monofilament will always have less plaque accumulation, and with less plaque accumulation, as per the Dragovich study, you'll have less inflammation and usually less post-op pain. In terms of sutures, most of our sutures in dental are a 3/8 needle. The reason for this is because of the nature of how we are grabbing tissue and then pulling up. Half needles can be very good for certain soft tissue procedures, but for most part, you have 3/8. So just understand the suture packet that you have, the size of it, the length of it, the needle length as well. Remember, when you're in the posterior region, it is much easier having a needle length of 16 plus millimeters. Quickly on suturing. Now, I know this is not a hands-on lecture, but one thing I think, and the reason I have this image is because it's a common mistake. Often when we start suturing, we grab tissue and we, not at a perpendicular axis, try and place the suture through. And what happens is essentially you can grab and bite the tissue too thin. You do want to get more into habit. This is a bit exaggerated, but getting the needle to come through at a perpendicular angle, grabbing a good thickness. Now, good thickness is usually at least 2 to 3 millimeters, and then bringing through on the other side. The reason for this, if you are grabbing thin areas, there is a good chance that once you start to tighten your suture, you may have tearing, especially if there's inflamed tissue in that area. Or during the healing process, when there's some inflammation, swelling, at that point, it can tear. Now, going into scalpels and handles. Again, having things ready can be very helpful. For the most part, having a 15 or 15C or a 12 or 12D will be your most common. Essentially using your number 15 for personally, using for lowers, and then using a 12D around third molars, although again, with particular axis you can get used to. It's not really important what blade that you use. What's more important is that it is sharp. Remember, once blade touches bone, it starts to blunt. So you may need a couple different blades, especially if you're going into different areas. And then in terms of scalpel handle, I highly recommend, if you don't already, to at least use rounded scalpel handles. Your control of the handle is much better. Obviously, you've got your traditional flat handles, and then you can get into really fancy angled handles, which are quite nice for periodontal surgery and kind of posterior areas. But the rounded handle is a very nice and very cost-effective way to just make your life a bit easier. Now, you have your elevators. So you have your molt elevators. These can come in different sizes. This is your classic periosteal elevator. Having a smaller boozer or molt 2 or 4 can also be a nice addition to have a little bit more control of reflection of your flap. Again, what else might I have? I might have some criers for more difficult third molars, a Luca curette. This is for degranulation. And then you may have some extra root elevators, again, for the more tricky cases. So in terms of equipment setup, very simply, this is kind of, you can take a screenshot here. You're thinking of luxators, you may be going a little bit finer, handpiece and burrs, Minnesota and biblock. You're starting to go into surgical, add in a molt elevator, add in scalpels, and then other things to consider is your saline. Surgical suction is also not to be understated. You need to see what you are doing, and we'll kind of show some cases a little bit later. So this is equipment basic on the left side, and then on the right side. So what I want to say here, in my practice, we do a lot of surgery, so we do have kits ready for surgery. So on the nurse, I've got this ready. On the right side, we have a surgical kit. Now, I'm not using this whole surgical kit. We use this for all our surgeries. But what you can see is LA, burrs, forceps, one luxator, Minnesota, and then in terms of the actual kit, there's just some periosteal elevator. So it looks like there's a lot going on there, but not that much. So in terms of being set up for success, you have to look at yourself and understand, am I ready to take on this case? Do I have pick the right case? Is my team trained? When you're doing something for the first time or you're getting into extractions more, having a good team setup is really important. And then thirdly, from a patient standpoint, obviously you want to make sure that medical conditions, dental examination, social history, all of that's understood, but also the patient to understand the expectations when it comes to actually the delivery of the tooth and what may be involved there. So informed consent, let's very quickly touch on that. So we have to understand that these are somewhat elective procedures. You do have to go through consent properly. You have to make it a shared decision. It has to be voluntary, it has to be in capacity, and you have to disclose what was the diagnosis, what was the prognosis, what are the risks and benefits, what are the complication risks. It is important, especially with the process, and we'll talk about complication communication. A lot has to come down to, number one, how you talk about complications. Complications, when spoken about in a confident way, actually build trust and usually often make the patient more likely to go ahead with that procedure, as opposed to not disclosing potential complication. And then of course, if certain things were to happen, that can be, obviously creates another conundrum of issues. And remember that we are in a privileged position in the health setting. Not having proper consent is equivalent to a lot of medical kind of misconduct. So just make sure that the patient understands, and make sure you are going about consent in the proper way, in terms of just making sure that patient really understands things are documented. And with consent, for extractions, we have a quite fairly standard document. We'll go through the considerations. I will go through that with the patient. I will have a patient sign for every procedure that they do. You can also consider financial consent, but for the focus, understanding this basic. So now we'll get into more of the clinical aspect. So one of my goals is, and one of the best parts of doing minimally invasive extractions is creating a great experience for patients. Patients do not come dreaming of having their extraction done. They are often very hesitant. They will delay extractions as long as possible. I was literally, my cab driver here, once he asked what I do, I said periodontics. He said, yes, I've been delaying these extractions for 3 months. And for him, it was the noises that specifically were one of the things that he brought up as an area of concern. But patients are often nervous, and when it comes to most of what we do in dentistry, extractions or surgery is where there is often a lot of fear. And so case selection and creating a great experience is what I want to help everyone teach. So case selection, I think we can all appreciate this is not a case to touch lightly. And what are the risks here? Obviously, access is a huge one. But where do you even begin access? Can you access this intraorally? Are you accessing from extraoral? What's the risk of mandible fracture? Mandible fracture is something to really consider once you start looking at third molars or thin mandibles, and depending on the age, osteoporosis and other things. So with case selection and risk assessment, you have to ask yourself, is it worth it? So how complex is the case? How complex is the patient? And then looking at your own personal ability. Oral surgery, extractions, surgery, there can be higher stress, and case selection can be a way to reduce that stress. And something for you to kind of just consider while you're building your competency and your skill set. And so you can kind of considerably build on your result. I can tell you that having a poor experience can definitely break your confidence and make it more difficult to get back into extractions. Now, with case selection and planning, there's no such thing as good luck. It's all about planning. So let's go into it. I'm not going to focus on this too much, but I do want you to just understand what is the medical conditions. Look at these things: age, diabetes, bleeding disorders, immunosuppressive. Is there preoperative antibiotics? Something to consider. If they have liver issues, is there consideration for their anticoagulants and their coagulation risks? If they have a history of head and neck cancer, where was it done? What was the stage? Where was the radiation field? Do you need to get a copy of those radiation fields? If they've got vitamin D deficiency or other deficiencies, is there a issue of healing? Smoking, alcohol, and a combination of these factors make a higher risk patient. Big things in terms of extraoral examination is their limitation of opening. I can't understate this enough. Where you quickly look in, you think, oh, yeah, we need to extract, you schedule it in, and then on the day, you feel like you can't access. Is this patient better done under sedation? Looking obviously at pain, swelling, systemic signs, airway, intraorally, are there tori, exostoses, and asking patients about their history of extractions as well. Looking at an x-ray, in terms of the tooth, what's the bone loss? Are there cracks? Is it root canal treated? Do you see any evidence of ankylosis? What's the density of the bone? How close is the sinus? How close is the nerve? In terms of impaction, what's the depth? What's the angulation? Do you think there's a cyst there? Should we be sending something for a biopsy? Should we be doing a CBCT if we think it'll change our plan? And let's use this as an example. If we don't look at the right side and we start off here, we can see here we've got the OPG. This is a 1-7 referred for extraction. And you would look and say, look, obviously it's approximating the sinus. There's potentially some sinus congestion. And seeing a communication is not evident. But we take a CBCT and have a look here. You can see quite clearly the communication with the sinus. You can see the inflammation in the sinus. By the way, remember that the most common reason for unilateral chronic sinusitis is dental pathology. Now, you can see how a 2D image does not give you the full picture. And so a CBCT, A, may make you consider, look, I'm not confident in managing this case, I'd like to refer. Or two, when I'm going about this, I'm looking, okay, where is this communication? Where are the roots? What is the angulation of the roots? How am I going to deliver this tooth minimally traumatic? And then how will I manage the OAC that is present here? When we look at sectioning, and again, case assessment, let's look at this 4-6. One of the things to consider is look at the condensing osteitis apically. We are understanding that there is potentially going to be some denser bone in that area. Thinking about, okay, where will the teeth move and how will we go about things? So again, a big thing I want to take away is sectioning is going to be critical, and we're going to touch on why that is critical. But it's actually going to be very critical for building a very big skill set in terms of minimally invasive extractions. And when you say sectioning, I had an immediate implant that I placed recently on a 2-1. And despite my best efforts, despite being gentle, despite rotating force, I could not remove this decoronated 2-1 until I sectioned it. So even centrals, even single rooted teeth sometimes need sectioning, especially if the goal is to be as gentle to the bone structure around. Local anesthesia. Just wanted to quickly touch on this because I do want to kind of focus on how do we create a great experience for patients. So there is some research behind this. How do we make this minimally uncomfortable? I don't I don't believe in the term atraumatic extraction. By nature, an extraction is, of course, traumatic. But how do we minimize it? And so how do we minimize the discomfort? Music is a big one, as I mentioned with the taxi driver that we had. Building trust with the patient, the speed of the procedure, comfort in terms of having a bite block. If there's also consideration of noise cancelling headphones if the patient prefers. Considering simple things like anti-inflammatories pre-procedure. There's a lot of evidence to show for those who do not have any issues taking, ibuprofen or anti-inflammatories or a short single dose of steroid an hour before the procedure will reduce post-operative swelling and pain considerably. In other patients, oral anxiolysis, and then in some patients, some sort of IV or GA sedation is what is needed to provide that positive experience. And then making sure post-op pain management is good. Obviously, your surgical technique will relate a lot to post-op pain, but then also understanding the patients and the patient risk. So with local anesthetic, my approach has changed over time. So with upper molars, I think it's pretty straightforward. Most of us would know a buccal infiltration and a palatal. The reason I have these CBCT slices is because when we're looking at the innovation, in an upper molar, you have separate innovation to your buccal and palatal. So it is cool for minimal issues to consider ensuring anesthetic in both areas. Sometimes there can be transfer and diffusion across, but why risk it? The goal with anesthetic is you do it once, you do it right, and you don't have to go back, because that's where pain, discomfort, slowing down, redoing anesthesia is working. Now, what has changed in my practice is I have started to do a lot less blocks, and even for mandibular molars, doing infiltrations. And what's really important is you have to imagine where is the root apex of this tooth for both upper and lower molars, but especially for lowers, because you have the density of the cortical plate. And so when you deliver the anesthetic, you want to minimize the distance from there to the root apex. The less the distance, and you can see here on this CBCT slice, that lingual plate is relatively thin. And so your lingual infiltration is actually the one that often will provide you pulpal anesthesia in your lower molar. And usually, again, I might overdo it, but more often than not, that means I don't have to come back. It also will make sure your accessory nerve innervation from a nerve to mylohyoid, in the 5 to 10% of cases that does have it, is also anesthetized. I would use 2 carpels, so one on the buccal and one on the lingual. For those who want to try this technique, it is important. So what I'll do initially, I'll put a few drops into the sulcus, let that diffuse, get soft tissue anesthesia. And then the second needle, or the second time going into that site, I actually am going to bone. And when you start injection, you actually feel the anesthesia almost diffusing between the periosteum and the bone and the muscle fibers above that. And so there's almost a tension, and you can almost feel the anesthesia sitting there. Now, if you want to be incredibly gentle and you want to make a palatal anesthesia really comfortable, the next step, what I do is, as I was saying, you do your buccal infiltration, wait for that to diffuse, place a second one into the buccal papilla, wait for that to diffuse, inject through the papilla till you get through into the palate. And so hopefully by this stage, you've slowly been infiltrating the palatal. It has been a comfortable anesthetic, and then you can go for number 4. So with the extractions, let's kind of break it down into steps. Firstly, detach the soft tissue. This can be done with a scalpel. It can be done with the actual thin luxator, gently working your way around the buccal to the palatal. You don't have to avoid the palatal, avoid the lingual, but you can help detach that soft tissue. Again, it doesn't matter what instrument you use, as long as you're careful, gentle, and working your way around. So next, really important, and hopefully this provides a lot of understanding of why have I had a difficult extraction. So it's understanding mechanics. So what that means is, often we're thinking like doctors, we do have to think a little about in delivery of a tooth, like we do in our composite and our pros, a little bit mechanically. Delivering a tooth is about space. It's all about how do I create space. If you think about your single rooted tooth that's had 80% period bone loss, there's a lot of space. There's space with the bone loss. The PDL is often inflamed, it's wide, so you've got space around the root. And so there's a lot of mobility to even begin with. And so space can be created by 3 ways: PDL widening, tooth separation, so sectioning teeth, and bone removal. And what I want us to focus on is, how do we get most of our space through the first 2? Not to say bone removal isn't necessary in certain cases, especially when it comes to being fast. However, in most cases, let's think about how can we preserve bone and create space. Remember, space. So let's take these 2 x-rays. So you've got this 2-5 with the almost S-curve root. You have to ask yourself, before you approach this, how is this tooth coming out? Can this tooth come out in one piece? The answer is it probably can't, unless you were to luxate around, get mobility, apply your forceps, and then displace the entire root buccally. And so in that process, you're going to remove and you're going to create your space through luxation and then removing the buccal bone, either directly with a burr or indirectly by just breaking the buccal plate as you deliver the tooth. So then the question is, how do I remove this tooth without doing that? And so what I want you to think about is, when you have these curves in roots and you have bone interlocking, now bone can compress. So you can, in a, let's say, upper posterior X section, we have type 4 bone, you can have bone compression, and that can lead to the space. So for example, you apply your forceps, you place buccal, you hold for 5 seconds, you place pressure on the palate, you hold for 5 seconds. If you can, mesiodistal, you are creating space through PDL widening and some compression of the bone. And then that can be enough to rotate the tooth out. But the teeth that can come out most minimally traumatic, if you think about it, are cone-shaped teeth. So you have your upper, single incisor, nice cone-shaped tooth, and a lot of the displacement is essentially all coming out in one piece. So as you're pulling the tooth out, there's no bone interlocking anywhere. You can rotate and essentially break the PDL fibers and take the tooth out in one piece. And so what we want to think about is, how do we turn complex root anatomy into less complex root tooth anatomy? And so let's say take a situation like this. Again, the CBCT slice can be very helpful. We can apply the luxator here on the lingual, but remember, we do have very thick cortical bone. So this could be potentially quite difficult to luxate without displacing on the buccal. Interproximally, you do have much softer bone. So think about, okay, where am I going to be delivering this tooth? If I push this buccally, I'm going to break the plate. If I push this lingually, it's going to be very hard for me to do that. And so how do I create space? Well, in this case, as I said, placing on the lingual is going to be very difficult. So where can I go? So let's place my luxator on the mesial and distal. Let's create space mesiodistally in that trabecular bone. If I apply my forceps, where would I be trying to move this tooth? Looking at this scan, I actually want to try and move this tooth mesially or distally. I'm preserving my buccal and lingual plate. In terms of bone removal, that is what you want to, because if you can maintain your buccal and lingual wall, even if there's more bone removal internally, and that's the selective bone removal, you want to control where the bone is removed. So creating some space mesiodistally, creating some separation, and then trying to rotate this tooth out. So let's go into other complex anatomy. In anatomy, it's beyond amazing how every tooth is its own fingerprint of complex anatomy structure. And so when we start thinking about sectioning, and how do we create these cone-shaped teeth? How do we create teeth? So you have one tooth, but with complex roots. How do you create lots of little teeth that can be delivered? And so it's about sectioning. And so these red lines are kind of indicating, and not all the case, obviously, some cases where you've already got some bone removal, some cases you have very soft bone, all these other factors that may change how you approach things. But when you look at these complex anatomies, sectioning and creating little pieces that you can rotate out, or even pieces that will break off. And by sectioning, breaking off, you then have a root piece that is more conical and you are more able to deliver in a minimally traumatic way. So touching on sectioning, understand your anatomy, understand where the furcation is. So, this image gives you a bit of a sense of averages. What's the separation between your mesiobuccal and distobuccal root, if there is one? What level is the furcation? You do have to section through the tooth into the furcation and use your x-rays to help you. So what are minimally invasive techniques? So back to this case. So you applied luxator, you applied for, why isn't this tooth canal? Well, again, we've talked about the curve and the curve here. So let's start looking at this one. So let's unpack it. So in this tooth with these two curves, there's two paths of where the tooth wants to come out. This top part, if we remove this, is fairly conical. So it does want to rotate out. This part, more apical, wants to come into this space. So if you try and pull this up, this will get locked by the bone here. If you try and push this here, you're going to get locked by the bone here. So what can we do? Well, we can the blue line is where you can selectively remove bone. So I'm not removing the buccal plate, but as I said, the goal is we're going to keep the buccal, keep the palatal and lingual. But interproximal, where you're not impacting on tooth, adjacent teeth, this is fair game. So let's carefully remove some bone from that blue line. And this is actually how I will start the procedure. I'm not going to necessarily wait or wait to have something break, but it will. So what I'll do is I'll get in there, I'll apply my luxator, and then I will also section this top piece out. And so once this piece comes out, I'll then get my luxator deeper, and this root piece, again, this is where good magnification, surgical suction will allow you to bring the root in. What about this tooth? These are the paths of movement. Also, another tip, you can get caught out by the interproximal. So sometimes this is where decoronating and sectioning and making sure your interproximal contacts as you're delivering a tooth is not going to impact on the distal tooth or the mesial. And with this distal curve, there's two paths, one part wanting to come out this way and one coming out that way. And so when you look at these molars under sectioning, and cross sections, again, understand with your mesial root, it's not conical. Your distal root tends to come out a lot easier because it is much more conical. And so with the mesial root, if you're finding that this bone around your figure eight is locking, maybe you have to remove that bone. Maybe you even have to section your mesial root further. So step one, measure to the furcation. Decoronate, section down, like so. If you need to, I'm not saying I will do this first up, but if you need to, you can section your mesial root further. It's all about creating cones. Now, again, you're locked, not feeling movement. Again, you can see quite cortical bone, lots of condensing osteitis. If you're feeling no mobility, section, again, we're leaving the buccal plate, we're leaving the lingual, interproximal in this furcation, start removing bone to create space for delivery. And so you might deliver the distal root first if it's more mobile, or the mesial root. So let's take this case, 2-6, we've measured to the furcation, we've decoronated. Patient had pulpal necrosis, apical parodontitis, didn't want to save the tooth. We've started sectioning. You can see here, distal and mesial buccal roots are separate. We've done a T-shaped incision, and we fractured each piece separately and then carefully worked our way around. Remember, detaching the soft tissue and rotating each piece out separately. Place the collagen sponge here and a suture to hold the sponge in, and like so. So another case, sectioning. And now in this case, it's a bit hard to see, but I did end up sectioning the mesial buccal. But what happened? My mesial buccal root fractured. And so you can see that there. So the distal buccal removed palatal. If you're not prepared, this can feel very stressful. How do I get my luxator in? How do I access? But with the right burrs, remember, it's all about space. I have a space in my distal buccal root apex already. What if I carefully remove this furcation bone, create myself a little purchase, and gently push this into that space? And just like that, you deliver what was stressful takes 10 seconds and no longer. And so often when you start sectioning, this happens on a routine basis, and it doesn't have to be difficult. So it's lower molar, you have a long roots, fairly dense bone. You start by sectioning, able to deliver the mesial roots first, but you can see some fracture of that interproximal plate. And you can, same concept here, the concept, where is my space? I'm moving into the distal. So I'm going to get my luxator gently there. I'm going to remove some extra furcation bone if I need to. You can see some burr marks there. And I deliver my distal root. So socket management, we'll quickly touch on this. Hopefully that's been a very helpful mindset in terms of approaching. Make sure you remove any sharp edges of bone. Remember, you want to control the healing process as much as possible. Sharp bone will create irritation, and then either you're going to have bone spicules form out or post-op pain increase. Make sure to curette as much as you can, especially but being careful avoiding nerves, sinuses, having again preparation to be able to quickly suture, have collagen dressings and such. Go through your post-op, talk about disinfective mouth rinses, talk about things like seeds, nuts, avoiding food impaction, quickly touching on complications. So acute complications, to guarantee not having surgical complications and not do any surgery. You don't stop driving and having these complications. It's not about not driving at all. It's about how do I do this as carefully as possible. But acute complications, things that are reversible, things like bruising, swelling, pain, post-op infection, where it is nothing that you have done clinically. If you've been very traumatic, the bone is fractured or things like that, you've left fractured pieces, yes, you can develop complication. So we want to kind of first differentiate expectations and patients having difficulty with the healing process versus an actual complication. So if it's fairly self-limiting, it's not really a complication. But what could be? Bleeding, ultra-antral communications not managed, dry sockets, dislodgement of teeth roots, fracture, failure to complete the procedure. So with bleeding, it really is about preoperative management, and then making sure, you've got a patient on aspirin and you are not sure, things clotting in terms of platelets and things like that, and you may feel okay, but if in doubt, just place your collagen dressing, suture, consider other things that may be needed. Tranexamic acid in particular. OACs, number one, I think where people get caught out the most is not being prepared. So using a CBCT may be what avoids this situation. And different cases will be managed differently. Smaller ones will be self-limiting and sort of collagen dressing, sutures, antibiotics, decongestions. But larger ones, you do want to consider other ways to manage this or referring. Dry sockets, again, is that a clinical error? Not usually. It's often an immune system, so finding out. Displacement, this is obviously something you do not want to happen in your practice ever. And so being very gentle, very controlled, and again, being very good in your case assessment. Tuberosity fractures, again, is it self-limiting? And again, how much of an issue? Obviously, this creates a tuberosity fracture of this extent where you've actually gone into the pterygoid, and of course that it can be quite major. So be in control. So if this does happen, stay calm, close the space, get antibiotics, have a good relationship with your local specialist. So in summary, let's finish up. So be prepared with informed consent. Make sure you have documented. With case selection and risk assessment, I see this as probably the most common mistake, not preparing or not seeing potential risks that may happen. With local anesthesia, be sure that you are profoundly numb. Now, I mentioned infiltrations. Having said that, if I'm doing third molars or multiple others, doing a block or a couple blocks per side, absolutely. With mechanics and anatomy, go in with a plan. Think of the cone. Minimally invasive techniques, again, thinking bone preservation. And then with surgery, just being prepared and planning. So hopefully that was a helpful presentation. And yeah, hopefully something people can share and got something out of it. For those who want to reach me, as I mentioned, I've got my email. I'll try and zoom in there a little bit. Alexander.Khominsky@gmail. Instagram is great. If you'd like to, work with me in terms of practicing in Melbourne, as James mentioned, I work in Malvern, Sandringham, and up in Albury-Wodonga now. Feel free to collaborate on referrals, and then obviously working in GDR as well.
Thank you so much. Almost right on time, I suppose. But Well, we've got some questions, we'll go through them. If anyone else has more questions while we go through these, please add them to the chat. Let's go through the first ones here. We've got Dr. 38 Bluestorm. Can we use a red band crown prep handpiece? I think we're talking about a electric handpiece if we can't use a surgical handpiece.
So, okay, so a red band, now, is there any air venting from a red band electric handpiece? I think there is, right?
Yeah, I used one today and there was definitely air coming out the front. Yes.
So essentially, no, I wouldn't recommend it. I think at the very minimum, you do need to invest in a rear venting surgical, 45-degree handpiece. They can range a little bit in costs, but having an air emphysema is not something you can ever really protect yourself against. So in my hand, for when you're starting to get into like sectioning or surgical, or you're into bone or tissue space, I wouldn't do that. But good question, and I'm sure again, many practices may not have invested in that, so it's probably reaching out to a few people. Feel free to kind of link and making that investment yourself.
I'll add to that. Like I will decoronate with a high speed, or use a red band, because that's still think of it as a crown prep kind of style kind of scenario. But when we go into sectioning, then I will switch to the 45-degree just for efficiency, in my hands anyway. We've got another question from 38 Bluestorm. Why do we section most molars? Is it to reduce bone loss for future implants?
So good question. So I guess you have to approach with extraction. Okay, what's the goal in our extraction? Is it removal of the tooth? Is it preservation of the area? Is it to make the experience as comfortable as possible? And so when I say most molars, again, if you've got a grade 2 to 3 mobile molar, and you can deliver the molar with minimal trauma, absolutely. The reason why we section most molars is because often anatomy is divergent. So especially if you take a first molar or first upper molar or lower molars, obviously when you have roots that are fusing, and that, for example, in terms of case selection, if you have a lower third molar or upper third molar with fused conical roots, often they're the easiest tooth to deliver, especially if there's nothing impacting the crown. But once you have divergent roots, you just have to ask yourself, how is this tooth coming out without something breaking? So the reason why we're sectioning is we're essentially controlling the break, because what could happen when you're luxating and applying forceps? In one scenario, your buccal plate breaks. Now, what does that mean? You mentioned implant, correct. So for a future implant, you're going to have less bone in that area for the future implant. Number two, patient recovery. When you've got the fracture plate, there is more healing process that needs to take place. And so your patient is more likely to go through a more difficult healing process. You want, for most of your patients, to have a very comfortable healing process. It's how you build, being able to do extractions in a way that has, is minimally invasive, but also has good post-op comfort, is a great way to build a practice, as opposed to, doing it in a way where every single time patient has, really significant post-op pain. So the reason why most molars, now again, not talking about thirds, first molars, second molars, is divergent roots, and then again, controlling the break.
Thank you for that. I agree as well. Yeah, I think my patients will have enjoyed the sectional extractions. And
one thing I will say with sectioning is the noise. Obviously, the sound of the drill cutting through. So if you have sensitive patients, having some sort of headphones, whether your practice or their own, can help with that.
Right. We've got our friend Dr. Daniel here. What's the name of that mouth opening forceps that you have in your surgical setup?
Mouth opening. Let me bring up. Daniel, let me see. Do you know what he's talking about?
I'm not sure.
So I've got, this is the setup I usually have. Mouth opening. Or is it these? These are lunges? I don't think so. Daniel, please confirm.
Please confirm, Daniel. We'll come back to that later. Dr. Martins, hi. Dr. Alex, for that S-shaped root, that premolar, how do you get to the middle part of that root?
It's a good question. So let me bring that image up. So with this case in particular, so the question is, how do you section at this point? So there's a couple ways. One is, in this particular case, where you have the access from the mesial, essentially, again, it's about access from your burr, your suction, your light. I use my, there was a Facebook comment today on DPI, I'm using my 10 times ergo loops and my S orchid light for all of these cases. So to be able to access and see something like this dissection, you do need good access and having a good surgical suction so you can see. So in this case, you would remove mesial bone until you can access and just kind of, sectioning through from the mesial angle. Now, if that's not kind of something that's possible, then you can, again, come from just top down. So you can kind of come top down, work your way across mesiodistally until essentially either you've drilled out that top piece or you've kind of controlled the break, and then you'll have access to this area with your burr and then working your way, sorry, people can't see my mouse, to that mesial, creating a point of leverage. And often when you're not doing this as regularly, obviously the fear can a little bit be, what if I, cut out this and then I have no point of leverage and then I'm stuck? Whereas, if I've got this big tooth, I can hopefully wiggle it all out together. And then if something breaks, probably coming back to it, having really good access and kind of, I guess, being ready for plan B. In this case, how would I gain more space and access? I would just, in this case, you've got no tooth here. I would preserve my buccal and palatal plate, and I would just keep removing, mesial bone carefully until I was able to get access to right to this point at the curve. And in this case, especially in a maxilla, looking at the trabecular pattern, the root will deliver fairly easily once you have that space.
Amazing. Yeah. I agree with that too. Dr. Vish, what is the difference between the Dynac reverse premium cutting and reverse cutting sutures?
The Dynac reverse premium. The
Slides.
premium. I think from memory, it's how the needle is treated. So I think it blunts less. But I would confirm and get back to you.
Got another question. Cat videos. Tricky part of section is knowing where the furcation is. How can I section without raising a flap?
Okay, so this is, again, very common. So the question is, how do I see a furcation? So I'll bring up an image. And so this might be, I guess, a good example. And so the mistake that could be made here is, how can I see this furcation accessing this way? I think step one now, Cap, thank you for your question. I think a lot of people have this issue. Number one is decoronating. a common mistake can be to try and section without decoronating. Sometimes you'll be okay, but number one, your actual burr length and axis, by not decoronating, there's an extra 8 to 10 mils of tooth structure you have to get through and maintain an angulation, which is much more difficult. So if you can decoronate, you're also removing your mesial distal contacts, and it's going to make your sectioning and access way better. So start by doing that. And then number two is understanding anatomy. So like that previous image I had, you can use your x-ray to measure. And if you think about, your mesial distal, you'll never really know, unless you're raising a full thickness flap into the furcation there. Buccal, okay, sure, you can raise a flap and see. So how would you know? So when you section, experience will teach you, but if you're sectioning and you don't see any bleeding coming from your sectioning space, it means you're not at the bone yet. You're still within tooth structure. And so if you're kind of sectioning through, there's no bleeding. Okay, keep going. Keep going. And then you get to the point where you see, there's blood starting to form between my, section pieces. Now you know you're through the furcation. If I show you this example here, again, getting to the furcation from the top here on this 3/6, that could easily be 11 mils. And so again, access, angulation, just decoronate first, as I did, and then you can see here, you can actually see where the furcation is in terms of the bone versus where the root piece is, and you don't have to go in as deep. So hopefully that helps answer that question, Cal.
Excellent. When you decoronate, everyone, try not to decoronate all the way to the gum. Leave like a 2 or 3 mils of tooth structure so that you can at least grab onto it bit by bit. Okay, we've got Dr. Celine. So in terms of removing bone, is it we're just trying to avoid buccal and lingual plate? Is that correct?
Correct. So I guess the question is, why is that important? So your buccal and lingual plate, and I guess they are the two, critical walls in terms of containing your blood clot for healing. If you have a thin buccal plate, it will, have some sort of resorption. Why is the interproximal less of an issue? And the caveat to that is you don't want to remove interproximal bone until you get to a tooth. If you get to the tooth, you are losing a wall of bone because now you have a root and dentine that doesn't have bone cells. So if we have a buccal and a lingual wall, and then mesiodistally, we have some room to remove before we get to the adjacent teeth. And so essentially by containing that, you have what's called a four-wall defect or a box, which is the most favorable for healing. So we just have a little bit more give. Now, in cases where your buccal or lingual plate is 3 mils thick, 4 mils thick, these are rare cases. You can remove some buccal and lingual bone around because you'll still preserve your four-wall bucket that will help contain. But it is rare. Most cases, even in favorable cases, your buccal wall might be 1.5 mils, 2 mils thick, but most cases are potentially less. And probably the secondary factor is buccal and lingual plates tend to be cortical. So there's less flexibility. So your interproximal is more trabecular. And so we have to think about, if we're not rotating the tooth out and we're sectioning root pieces, we can, by removing some of that interproximal bowl, we have some more compression and space. We can kind of luxate from one end to the other.
Thank you very much for that very thorough answer. Let's go on to Dr. Kumar for orthodontic tooth removal. I assume premolars. Do you reckon remove all of the premolars without luxating a tooth, just using forceps?
So again, good question. Probably comes down to the age. When you have immature immature periodontal ligaments, there's a lot more vascularity around them. The density of the fibers are not as great. Often with your upper premolars, in the case where it's a single, rooted, the question is, would you go without luxating? Personally, I have never removed a tooth. I think even honestly in pediatrics, and maybe that's just me, without luxating first, unless it was grade 3 or grade 2 mobile already. Number one, it's a way to just test, is your LA working? Does the patient have a sense of pressure? But I think luxating is important to give you an understanding of the anatomy, the bone, the compression before. Now, again, in a young patient, maybe you don't need to. And the bone compression and things like that, you'll deliver things fairly quickly, just getting forceps, rotating or placing buccal pressure, because in the end, even if you do lose some bone, the teeth will be moved to close the space, and that will bring bone with it. But I think from, just, I guess, having that habit, and personally, I would always use a luxator, but I don't know, James.
I'll show you some of my experience. Yeah, so younger people, you can always give it a little jiggle if it's mobile, rip it out. But people who are adults, you're gonna have to luxate anyway. You might get away with it, maybe a little bit of rotation on the lower premolar with a more rounded cross section. Sometimes with patients who need premolars out, they might be intruded, so you can't even lift it out. You might have to actually do a surgical extraction. Some of these premolars might be, I forgot the word, welded to the bone. What's that word? Fused. So you have to actually raise a flap and cut it away. So I've done that a few times as well. So they can be a bit tricky. So it's case dependent. But yeah, definitely I would luxate. Let's go to the next one. We've got Cap again here. This is going back to that S-shaped root. If we didn't have that mesial space, how would we get rid of that tooth? How would you approach?
Give me 1 second. I'm trying to duplicate my slide and pretend I am sectioning for this. 1 second.
While you're drawing that, I'll just promote our GDR program. So extractions is we have a year-long program called the Dental Residency. If you have not heard of it, it is a 5-weekend live in-person program designed for early career dentists or dentists who would like a refresh and update. Extractions is one of the modules that we cover in the residency. We also have online modules covering perio, ergonomics. You can see on the slide there. But essentially, it's a program designed to level your skills up on top of what you've learned at university. University gives you a nice, safe level of practicing dentistry, and we want to help you get to your next level. On top of that, we also acknowledge the importance of mentorship. So if you don't have a solid mentorship program at work, or if you would like a second or third opinion outside of work, then we have that right mentorship program for you. It goes over 9 to 10 sessions there as part of the program. So definitely I would consider this program for you. If you decide to do all these modules individually, you can go to this list later, or you can download our handbook. I'll put the link below later. It would be about $22,000. But if you go through GDR, it's $13,950. So I would implore you to have a look at it and consider it. And we also have an early bird offer with $3,000 worth of goodies. So have a look at that as well. Take a photo if you'd like, and visit our website for more information. Back to you, Alex.
All right, quickly. I've tried to quickly draw something. So I think both questions are related to, what happens if you've got a tooth there. So ignore these darker blue lines. Yep, you can see that. So imagine there's a tooth here, mesial. So my first section will come through the top, and I will remove this mesial portion. So I've now created space on my mesial. If I feel, again, in delivery, you have to remember this distal half is still present, and this will want to go in a different direction. So then now I have access to make another cut at this angle. I can then deliver the second coronal half. And so I've delivered 1, 2, and then now, again, with good suction, with the fine carbide comet burr that I showed, I can get my burr down here, remove this, and get a fine luxator and deliver into it. And so I really love these questions, because this is the kind of planning and consideration you have to have in terms of, that mechanics. How do I create the space? We think about it so much in terms of pros and composites, and so we don't apply that same level of thinking sometimes with extraction, but you do. And by doing so and thinking about where will the space be created, or where will I get stuck, so that's how I would go about that case. And of course, if you got completely stuck, you can always draw back to removing that buccal bone and flicking it out that way. On occasion, that is what happens, but often, again, you'll be surprised, especially where bone is in supracortical, you can get away without doing that.
Thank you. And by the way, guys, that's a really nice burr, that Comet Blue one. I started using it last year, and it's really helped with my sectioning as well, and real difficult extractions. Got a little picture there. There you go. One of the blue branches. I love it. Nice, long, and quite sturdy. Okay, we've got another one. When do you go from a non-surgical to sectioning, to a full surgical, to bailing out and referring, then going home and crying?
I was going to say, this is a whole sandwich. Hi, Michael. Thanks for the question. So non-surgical to sectioning. I think, these days and maybe also a bit of case selection. Most of the cases that I'm extracting are not, let's say, the most straightforward. Obviously, if you do have straightforward perio involved, as a single unilocular teeth you place a luxator, you've already got some ability, single rooted, I guess keep it. I don't even like the term non-surgical. Like, since when is taking out a tooth a non-surgical procedure? But anyway, beside that point. But having said that, and my nurses are always ready to have a handpiece and burr set up, because it comes up pretty often. So I think number one is case selection. So if you feel like there's multiple routes, you feel like there's going to be some challenges, just have your handpiece and burr set up. In terms of a full surgical, so I'm going to say here, raising a flap, removing bone. The only times I will start off with a full thickness flap and raising bone to remove, honestly, is third molars. Anything second molar onwards, unless there's a separate issue, which is there's a large buccal bone infection and I'm going to be grafting, which is a little bit of a different approach. I find that if you can get very experienced with your hand pieces and sectioning and the space configuration, you often won't ever need to raise the thickness flap for the removal of tooth, except, and not even except, but even if you're so I have cases of ankylosis. So raising a flap is not necessarily going to make it easier for you luxating the tooth out, because it's not going to luxate out anyway. So you might as well section and remove the tooth internally through your socket, preserving that buccal bone as much as possible. So hopefully that answers. And then in terms of bailing out and referring, look, this is a personal one, but I think if you're spending, let's say 10, 15 minutes and you're making zero progress, so I think probably in terms of your mindset, you have to make progress fairly quickly. And so what I mean by that is, if you're, Luxating for 5-10 minutes, making no headway. Okay, you can't just keep doing it and hoping that, okay, if I do this for 30 minutes, at some point it'll give. Like it might, but you're not being kind of progressive. So start sectioning. Let's say I had that premolar case and I'm not getting that tooth out. Let's say I've done all my things and I'm still not removing it. Okay, at that case, it's been 5-10, probably let's say 10 minutes, nothing's moved, and I keep kind of getting my burn, keep creating space, still no. Okay, at that point, maybe I'll raise a small flap, get rid of my buccal bone, get the tooth out if I need to. But what I want to get at is with the sectioning in particular and your bone removal within the socket or furcation bone removal within the socket, if you're not having progression, keep removing, more of your furcation bone. Don't just kind of keep luxating and not really getting progress. Or again, maybe you have that mesial root of a lower molar that has the figure 8. Maybe instead of removing bone, actually section the root further and you will kind of get better access. In terms of referring, I think ideally the referral in cases that need a referral happen before you've started. And that's the case selection piece. So, really tricky cases, maybe think about a CBCT if you have access. But, you have to kind of just put your patient's perspective in mind. If they're not comfortable, if they're not able to go further, it's okay to just stop. I had those cases early in my career, and, you get the phone, you look after them, and it's okay. Things will happen. Don't keep going, especially where you feel like you're out of your control.
In the past, when I've had troubles, it's usually from a lack of vision. If I've just put a forceps on a molar without sectioning, and I just give it a little, I thought I'd give it a jiggle, and I'll crack the tooth, and the roots are there, but they're all subcrestal, and I can't get a luxating. Everything's so firm, and I've got to section it. And then if a section is still so deep, then I end up doing a surgical. So, now I'm more proactive in just going straight to sectioning. Something that you might want to think about doing as well, Michael. But it just depends on the scenario. You also got to tell the patient this is a very difficult molar, especially if it's one of your ones that you're not used to doing quite often, and they understand they might take a bit longer. So, like what Alex said, if you feel like it's going to be a surgical and you're not comfortable yet doing it, then maybe preemptively refer it. But if you are accidentally in that situation, if you got time, and you got vision, more importantly, then if you don't have vision, then make vision. If you're comfortable raising a flap and suturing up, as long as you run on time and you take care of the patient. But it's case selection, I suppose. Okay, we've got Navjeet here. How much time should we spend for a tricky exo? We'll have this as our last question.
Okay. All right, last two. Navjeet, hi. Lovely meeting you. How much time should we spend for a tricky exo? Look, I think how much time, number one, is probably patient-based. What's the maximum time you would want a patient in shade dealing with an extraction? Look, ideally, you're not going for a single tooth. Obviously, we're talking about multiple. We can talk about oral axial-lysis, other things to manage. If you're doing a full clearance for a patient under LA, they might be in the chair for like 3 hours. And sometimes that's okay. Like it is what the case is. So for a single tooth, I would say ideally not more than 45 to 60 minutes. I don't know. Is that? You think that's within reason, James?
If it's tricky, I still book 60 minutes. But usually I get it out sooner. But I think that's for my own reassurance and peace of mind. But yeah, it depends on your confidence. Yeah, 45 would be fair. If you're very early, in 60 minutes to 90 minutes, give the patient some Valium, time will fly for them, and then they're not so stressed about it as well.
Yeah, and that's a big factor as well for patients that are not kind of more nervous. But yeah, do remember that, when you do a full clearance under local, it's taking a lot longer than what a single tricky tooth might take. But yeah, hopefully that kind of gives a metric, I guess. All right, last one. Thank you everyone for the questions. Hopefully it's been very helpful. And if there's more questions, feel free to just DM me on Instagram, and happy to answer them as well.
Any tips on upper fours with very apical furcation?
So the average upper four, the furcation is usually 7 mils from the CEJ. So in the cases where you do have a furcation, it is most often fairly apical. And the answer is, again, a case selection, thickness of your buccal plate a little bit. Potentially you could remove it, but are you in one piece? But the answer is getting used to working with sectioning. So what that means is you have to section all the way down there. So if you know that the average is 7 mils from the CEJ, you've decoronated, you've left, as James said, 3 mils above the CEJ as to have some root to grab. So 3 plus 7, you've got 10 mils to get through before you're going to get to that furcation. Then you apply your luxator, you separate the buccal palatal fragments, and then in that case, in a premolar specifically, essentially your two roots become like very conical shaped teeth. And so you tend to be able to grab the palate, rotate it out, or gently luxate it. One thing I'll mention is when you're sectioning, a common mistake can be to have a very thin section. When you have a very thin section between roots, when you start moving one root, it starts knocking into the other very quickly. So when you section, you may need to go back and forth a little bit just to give some root separation so that when you deliver one tooth, it doesn't knock into the other. And then once the palatal is delivered, again, being careful with the buccal and probably getting a luxatus from mesial and distal and trying to rotate the buccal root into the palatal space. So hopefully that answers your question, Cap.
Yeah.
Great questions. I'm sure everyone's got the same questions in mind.
Questions. I hope you all learned a lot. And please, I've got a posted link there in the chat there if you'd like to sign up for the residency or just like to know a bit more information. Otherwise, thank you all for coming. Feel free to message us anytime. Thank you again. We'll see you next time.
Thanks, everyone.